There are a couple of questions here that I will read that people have given and will ask. So one of the questions was actually a very important one. Dr. Lemanne said that different sections of the tumor may have different preferred macronutrients, carbs, fats, or proteins. How can this be reconciled with my statement that all cancer cells are fermenters?
Want me to answer that, or do you want to answer that?
You give your answer first, and then I'll give you mine.
Oh.
And I'll give a third.
And your third.
I think I'll take the last word, but, you know, I don't think it can be reconciled, but it certainly fits with what we see clinically, and that's that we can't have a patient that responds in the early stages to any intervention, including the ketogenic diet, intermittent fasting, chemotherapy, radiation, who stops responding at some point to any or all of those interventions. So there is evidence clinically, certainly, for tumor heterogeneity. As far as the study that I was referencing in the talk, that was a study done on humans with lung cancer, non-small cell lung cancer specifically, which is known to be very heterogeneous in both between patients and within patients. So I think that there's, there certainly needs to be more work done to look at that, and I'll let Dr. Seyfried defend his idea, but clinically, many patients do eventually fail the ketogenic diet. So although it provides some benefit in certain situations, it's not yet been shown by itself or in the combinations of treatments that we've been using it with so far to be, the answer. So certainly new modalities such as hyperbaric oxygen therapy and are promising. Those are still in preclinical trials. We hope to see clinical trials pan out, and we hope to learn how to use all of these things together, which seems to be our best, give us the best results so far. Cancer is something that's very protean, and we, in the sense of the god Proteus who can change shape. And so the more that we throw at it so far, the better we seem to do.
Okay. The question is actually an extremely important one because we've looked into this ourselves. There are papers, especially for fat. People say fat makes cancer grow faster. And I said cancers ferment, and you can't ferment fat. So what is the molecular mechanism by which fat makes cancers grow faster? And what fat does is it uncouples the mitochondria, forcing the cell to use either more glucose or glutamine through the fermentation process. So it's actually an indirect. Fat will make the cancer grow faster by forcing more fermentation from glucose and glutamine. And there's some nice papers to show that. Because fat uncouples the mitochondria. Therefore, the cell senses the even further oxygen deficiency, and then they take up more glucose through glycolytic pathway and more glutamine through the glutaminolysis pathway. So it's really kind of it looks like it's making it, but it's through upregulating fermentation. And that's nice.
I'll just add one other thing. We're finding that metastatic cancer cells seem to be able to reactivate mitochondrial function. Now, a lot of times that's impaired in some way because of the damage you talked about, but often, and this gets at the heterogeneity of the issue, often these cancer cells may be in different metabolic sort of flexibility states. And so in some cases, we see a reactivation of mitochondria and the ability to use fat.
Yeah, what data show the reactivation of mitochondria? What is the experiment?
What's that?
What is the experiment showing how mitochondria can be reactivated in the metastatic sense?
Yes, primarily seahorse we're seeing.
So when you look at Warburg said this, seahorse is based on oxygen consumption. Yeah. Many cancer cells consume massive amounts of oxygen. It's not linked to OXPHOS. So if they're still throwing out lactic acid, and they're making, this is a clear indication that they're not getting oxygen. They're taking in, some cancer cells take tremendous in oxygen, but it's unlinked, okay? And they're making ATP through the glutamine. So you take glucose and glutamine away, they croak. All right, so seahorse only gives us indirect information about this, All right, so we've looked into that. Let me get another one here. Tumors relapse appears to occur from resistant tumor stem cells, which appear to mutate for chemoresistance. Any research on the role of mitochondria in these stem cells? Most stem cells have very immature mitochondria, so they're fermenters anyway. In fact, most of the stem cells in our body during development are anaerobic fermenters. They're not aerobic fermenters. There's a difference between anaerobic fermentation. When oxygen comes into the environment, we get an explosion of new energy, and that's because you have functional mitochondria. Now, cancer stem cells are locked into the anaerobic, they're locked into fermentation. So they're the same thing. You can see tremendous lactic acid being produced from stem cells. So they're clearly telling us they have damaged respiration. Comment on the common use of glutamine for cancer patients to support gut barrier post-chemo. This is a question that's raised so many times, like they give cancer patients a high-dose glutamine to restore their gut following chemo. How do we deal with this problem? We don't give chemo. The problem's solved.
Problem solved.
Okay, why would anyone? The absurdity of chemo, think about it for a minute, is to stop the proliferation of the cancer cells, because you're going to, chemotherapy is either breaking the cytoskeletal proteins to stop proliferation, or it's to break up DNA to cause base pair changes in the DNA. So everything chemo is doing is to stop proliferation. The cells can't divide unless they have a fuel. Take away the fuel, you get the same end result. They stop proliferating. So why are we doing all this?
So until the studies are done in human that prove that other things are going to cure what are curable cancers with chemotherapy now, such as certain lymphomas, testicular cancers, and several others, we would recommend avoiding glutamine loads with those particular chemotherapy patients. And what I mean by a glutamine load is anything that you take in a pill. So glutamine is made, it's made by the body normally. It's not something that you have to ingest to have in your body. And so you can't avoid glutamine specifically completely. And it's in many, many animal foods. You can't avoid it if you're eating animal protein. So, but specifically adding glutamine to a chemotherapy regimen would probably be unwise with what we know right now about many, many tumors very much being avid for glutamine. So in my practice, we do avoid glutamine loads. It is effective in preventing gut problems from chemotherapy, and it is effective in some patients in preventing neuropathy, but there are other ways to do that, and so I would recommend going in those directions.
Another glutamine question: can we inhibit glutamine through diet or supplementation, i.e. not using DON? In other words, how can nutritionists support decreasing glutamine? I think you answered in part that. There's another, we're testing the EGCG, the
Green tea.
The green tea extract. We're using, I don't know, the problem with that is it works through the mechanism of glutamate dehydrogenase. This is a different pathway than the transamination reaction to get glutamine. There's two different ways to get glutamine to generate energy. One is a glutamate dehydrogenase enzyme, and the other one is a transamination reaction. And the glutamate dehydrogenase is actually a big, bulky, it's really powerful. I don't know if green tea by itself is going to be sufficient to do that, but it could very well do it, especially in humans, if you give enough of it. And I don't know if there's any upper limit toxicity with EGCG. Have you seen any of that?
So EGCG was something that we talked about last night with Glenn Saban's book. That was something that he used in great quantities. The quantities that have been used in the Mayo Clinic studies in human clinical trials in chronic lymphocytic leukemia were in the 4 grams per day orally range. Now, there was some effect in some of the chronic lymphocytic leukemia patients with those particular doses. Lower doses were not effective. There is toxicity in some people with those doses. It's hepatotoxic. So if you're going to take or recommend those doses, the patient must be under the care of a physician who's measuring hepatic function at least monthly during the time that the patient is on those doses. There's also synergy in the Mayo Clinic studies with curcumin, also in large doses, 2 to 4 grams per day, also hepatotoxic in some patients. And again, a physician must be following the liver function tests in patients who are choosing to use those two supplements either separately or together. But there does appear to be some synergy in terms of clinical response in chronic lymphocytic leukemia. There are a lot of preclinical studies looking at those two supplements with some good effect. Curcumin has been shown to decrease the size of hepatic metastases of pancreatic cancer in animal models, but those were at doses that required intravenous infusions, and that's been studied in Europe but has not been studied nor approved in the United States.
Here's a question for Dr. Hursting.
Yes.
Diet-induced weight loss via low fat. Have you tried via ketogenic diet or high fat?
I knew that was coming. Underway now. That I will say there our low carb calorie restriction gets you pretty close. So we're getting some ketone body formation. I wouldn't say it's in the range of your ratio yet. So it prompted us to go to a ketogenic diet. And so
Yeah. Well, you know, I did all the like you did, calorie restriction. It works great, but nobody's interested.
nobody's
in
going
it,
to do it. Yeah.
right? So ketogenic diets are kind of like, oh, I can do something rather than starve, right?
Yeah. I'm
So-
intrigued by the 5-2, which keeps you, there's 2 days of essentially a very low carbohydrate, low calorie diet, and then 5 days of what you would say is a prudent, maybe like a Mediterranean style diet is how we
Right.
approached it. And, it's just above the ketogenic range, but boy, it sure worked well, and people seem to like it. I've started to try to do it. I'm doing 7 days of the 5 so far. I haven't quite made it to the 2, but so I'm on my 4th month of 7 by 7 or whatever I'm doing. But it's, but I do think that has some practicality that's appealing.
Well, here's another one. Can you comment if there is a difference in cancer risk with metabolically healthy obese?
Oh, that's a great question. That's a definite area of interest right now. There are estimates go from maybe 10, even 20% of normal weight, normal BMI that are folks that have inflammation and other components that are metabolically perturbed. I can't think of anyone that's gotten any data yet epidemiologically. We've mimicked it in mice, and for sure. I mean, we've got skinny mice with the metabolic perturbations you would associate with obesity, and they're prone just like the obese. And so, based on mice, I would say that that's a clear picture. I don't know of anybody that has the epi yet. I know that there are a number of groups trying to look at that.
Yeah, well, there's some obese people that have no their C-reactive protein, their glucose is low, everything is perfect.
Yes.
They just happen to be carrying a lot of extra weight.
Yep.
The linkage with cancer, in my mind, comes when you have obese with systemic inflammation. And that's why whenever I go to the physician for blood work, I always ask, can I see my C-reactive protein? Because that tells you right away whether you have a systemic inflammation, puts you at risk. But if you're obese and you have very low C-reactive protein, your blood sugar is low, your insulin is low, I mean, you're really just a heavy person. So not all obesity, I think, is associated with the pathological risk for cancer.
That's right. They kind of refer to it as the fit fat, where you're this healthy obese population. I think there's a little more data on that side of the coin, and that looks encouraging. But I was struck by the range, as we've gotten into more precise measures. We've got to get away from BMI as our measure of this story. But thank you. Talk about precision medicine. We really that's critical. But I've been struck by women. My clinical colleague, they got one of these fancy DEXA instruments that get you high resolution, and women at the same BMI could vary 12-fold in their visceral adipose tissue, which in my mind is probably one of the targets. And so That just should, if we're in Seattle and we're still talking about BMI, that's not probably where we want to be.
Right, right. Here's another one. Can the beneficial effect of bariatric surgery be mediated by the microbiome changes which occur in the patient post-surgery?
Yeah, thank you, Scott, if that's your question. That's the suggestion. In fact, part of this next experiment we're going to do is we're going to do the fecal transfer, where we take the microbiome, from the surgery-treated mice and put them into a non-surgery and vice versa. So to test that, hopefully in an experimentally sound way. But that certainly the 16S looks very different, and that's what the human data suggests too. Is that this is perhaps one of the bigger sledgehammers on microbiome is this bariatric surgery. So that's our working hypothesis right now.
Yeah, and the other one is after spending the morning talking about high fiber diets and microbiome, how do you see ketogenic diet interacting with gut microbiome health and cancer prevention? And right now, I don't know if anybody has started measuring microbiome in people on ketogenic diets. Do you know of anybody doing that? We are planning to do it in the mouse, but I don't know if how well that's been looked at. In other words, I'm sure the ketogenic diet does things to your microbiome.
Yes.
Right? I mean, it's got to be. But I think that's another area that would probably
I think you're right. Calorie restriction has been looked at, and it's a big hit on the.
I think a lot of it would be overlapping with calorie restriction.
I think so too. Yeah.
That would be what I would predict.
Yep, agreed.
Ketogenic diets and cancer treatment. Any concerns about recurrence when we revert back to the normal diet?
I have an answer for that. So there was an interesting Veterans Administration study. It was an observational study looking at veterans on the ketogenic diet. And there were not very many patients who ended up being evaluable on this trial. I think there were several dozen who started and 11 who ended up being evaluated and being evaluable. And there was one patient with melanoma who had been on the ketogenic diet, as were all of these veterans, as long as they could, who actually did have a regression of disease, and actually at the end of I think it was 2 years, stopped the ketogenic diet and remained disease-free at the time of the writing of the article, which was about a year after that. So there is some precedent for people being able to go off the ketogenic diet. I don't know what's going to happen to that man in the distant future. We'll have to see. But that was an interesting single case that I can think of that has been published about that topic.
Okay. What work has evaluated the ketogenic diet for metastatic ovarian cancer? Does ketogenic diet and chemo and hyperbaric oxygen make sense? And the answer is yes. And the Turkish group has a beautiful case of stage 4 ovarian cancer that appeared just as the breast cancer, the stage 4 breast cancer. We're seeing the same thing. And all the stage 4s, they only do stage 4. They only deal with terminal patients, and they're rescuing about 50% of them for all the different kinds of cancer. And ovarian is one of them.
And they do give chemotherapy in the Turkish clinic.
Say again?
They do give chemotherapy in the Turkish clinic with these cases.
Yeah. Is the ketogenic diet contraindicated in people with issues with fat digestion, gallbladder disease, et cetera, and cancer? And that's an extremely important point.
In my clinic, I haven't had trouble with patients who have gallbladder problems. In fact, their gallbladder problems kind of calmed down somewhat. Now, it's not impossible that we could see that. In terms of difficulties with fat absorption, that can present a problem. You can try things like pancreatic enzymes. You can start slowly and gradually increase the fat intake to see if you can build some tolerance. But in general, that seems to be a rare problem. It's not a prominent problem, even in patients who identify themselves as having difficulty digesting fat. What seems to be more of a problem is people who feel that they aesthetically dislike fatty foods. And I've found that seems to be a predictor of discontinuation much more than a declaration that they've had trouble digesting fatty foods in the past.
Another concern could be the rare case of carnitine deficiency. There's an inborn error of metabolism, a carnitine deficiency, because in order to make ketones from ketogenic diets, you have to be able to bring the fats into the mitochondria. And if you have an inherited mutation in one of these, it could be, but that's very, very rare. It's one of those rare.
And when we do the ketogenic diet, we actually measure the blood ketones, so we know if somebody's not getting into ketosis, and we haven't run into that particular inborn error of metabolism, but I'll watch out for it.
Yeah, but the fact that you do that tells you whether, now if you have someone on the ketogenic diet and they can't make ketones, that's might indicate that.
Yeah.
The other thing too is liver. If you have extensive liver involvement, because the hepatocytes are the cells that are going to be making the ketones, and if you have extensive liver damage, it's kind of difficult to push it too hard.
Patients who have patients will have normal liver function on paper at least until about half of the liver is replaced by cancer, and at that point it's difficult to get any nutrition into the patient, whether ketogenic or anything else, and they typically do prefer carbohydrates and will eject forcibly anything else. So that does present a problem, but those patients are somewhat rare. Hopefully we get to treat before that occurrence.
From excellent work. This is for Dr. Lemanne. What are your thoughts on using ketogenic diet as a preventive methodology for cancers?
Well, you know, prevention is rather thankless, but I do think that, you know, and Dr. Hursting's work is really interesting. It makes me wonder, and maybe you can add to this, is something driving obesity and cancer that's separate from either of them, rather than them being causally related. But, you know, certainly avoiding obesity in the first place, if possible, is helpful. I think that intermittent fasting is probably a very powerful way of kind of resetting things if there are if there is some cancer activity. Whether the ketogenic diet is effective in preventing cancer, we don't know yet. I think animal studies are pointing possibly in that direction. It's hard to separate the ketogenic diet from caloric restriction, at least in my mind. I'm still, you know, looking at both of those as really powerful ways of adjusting metabolism. If I had to choose one or the other today, I would say that intermittent fasting might be a little bit more important than being in full ketosis all of the time in terms of preventing disease. But I could be wrong about that, and we'll see what the data show in the future. But those are my thoughts at the present, that caloric energy restriction, intermittent fasting, ketogenic diet are a little bit inseparable, but being in strict ketosis at every minute may not be as important as having some breaks in caloric intake.
Yeah, I agree with that. In chapter 19 of my book, I wrote about cancer prevention. And basically, as I said, if you keep your mitochondria healthy, the probability of getting cancer is much, much lower. And how you do that is intermittent fasting, calorie restrictions, ketogenic diets. And the mechanism by which that works is through the coenzyme Q couple in the mitochondria. When you burn ketones, you keep the co-Q couple in the oxidized state rather than in the half-reduced state, thereby producing fewer reactive oxygen species and also contributing to the delta G prime of ATP hydrolysis in the mitochondria. All of this essentially reduces entropy, and entropy is the second law of thermodynamics, which is disorder. So when you keep your mitochondria in a healthy state, you actually delay entropy. And basically, that's all of that will prevent cancer. That's the kind of the bioenergetic explanation for that.
I've heard an argument that exercise is important in kind of pushing the mitochondria in the healthy direction.
Absolutely.
Tell us about that a little bit.
No, absolutely. The exercise issue is also an extremely important component in keeping the energetic system of the cell healthy. All of that comes together, I think, as a lifestyle issue. And then, you know, when you fast for long periods of time, when I'm talking like 21 days, when you start getting out. Now, be careful of starvation. There's a threshold that you pass when what we call healthy therapeutic fasting. then transitions into starvation. Starvation is a pathological state where you start to digest your muscles, not just your fat. So when you do that, then you enter into a very serious pathological state. So fasting is healthy up to a point, but if you take it too far, and I have spoken with the late George Cahill, the guru on starvation in humans, at long conversations about these kinds of things and what happens to the human body when the human body begins to starve. It's a very, very pathological state. But periodic fasting and this kind of approach, it's so you can't go too long on this. The healthy human person with normal weight can fast for about 40 days. Now, Cahill fasted guys that weighed 200, 400 pounds for 6 months on water-only fasting. And there's articles written on this. And all the vitamins are actually contained in your fat, your liver. You have very little vitamin supplementation. And your bones contain the minerals. So we're actually supremely designed to starve. We evolved as a starving species. The problem is now we have so much carbohydrate in our diets, and it's not willpower. It's diets that are forcing our bodies to take in and store all this excess glucose. And every time you turn around, we're getting hit with all, right? Everything. We didn't evolve to eat, this kind of stuff. So now we have the obesity epidemic, we have the inflammation, and we have all these chronic diseases. So anyway, are there any statistics looking at cancer? Okay, we just went over that. What about exogenous ketones? People now are making all these ketone drinks. All these companies are getting involved with this. Some might be okay, some might not be okay. I haven't tested them all, but there's a lot of Keto Force, and you have Nutritious. There's all kinds of ketone supplements. I don't know what to say. They've asked me to look into this. If you're on a ketogenic diet, my friend Dominic D'Agostino, who's really into this stuff, it was very interesting. One of my students fasted and got her blood sugar down to about 38 milligrams per deciliter, and her ketones up at about, I think it was like 6 or 7 millimolar. So I sent the meter to Dominic, and I said, look, Dom, look what we did, 4 days of fasting. I didn't hear from him for about a week. Then all of a sudden he comes back with his meter, and he says 25 milligrams per deciliter. He fasted for 4 days and then chugged his ketone extract. And he was able to push his blood sugars down to 25 milligram per deciliter, right? And he was in therapeutic ketosis with about 7 millimolar. So he was fine. He said he saw God, but other than that, he was fine. One more question. I think that's it.
Oh, that's it?
Yeah, that's it. I don't see any more here.
All right. Well, do you have any final statements? Would you each
No,
like
I want to
make...
thank you all for your attention, and it was great to hear
Okay.
you distinguished professors, and learned a lot at this meeting. Any final words?
Okay. You want them at the table or standing? All right. Would you stand here for the photographer, all three of you, please?
Okay.
Thank you.
You want to stand?